Hey everybody, Dr. Jake Bush here. So this video is intended to help undergraduate, or for that matter, any nursing student that is new to nursing and is trying to understand those mental health nursing concepts. So this particular video will focus on depression, how do we assess it, and how do we treat it. Now I'm going to make a separate video that relates or will review psychotropic medications, antidepressants specific to treating depression. So this video is primarily going to cover, what does it look like? What does this patient look like when they present to us? The characteristics, signs, and symptoms. We'll touch a little bit on standardized scales, and we'll do a brief overview of treatments. Now, please remember my disclaimer. I'm going to post it on this side of the video right here. This video is not to substitute for any kind of medical advice from a qualified healthcare professional. It's for educational and information intention purposes only, okay? And, all right, let's get started. So, depression. Now, one thing you'll see me kind of look down, I'm of this age where you'll see me grab my glasses from time to time, okay? I just had a birthday not too long ago, and I turned the ripe old age of 46. So I don't know if that means I need bifocals, because I'm having a hard time switching between looking close and, of course, distance, looking far away. But I'm working, y'all, on a comic book. And so these are a lot of my notes. And also, I've got a little 3x5 card of things I want to make sure that I talk about. So, anyways. Okay, depression. It is one of the most common mental health diagnoses. I think I read not too long ago, was it something like 70 million people in the U.S. have had depression at some point in their life. It's a lot, okay? The two most common mental health diagnoses that people have to deal with are depression and anxiety. And when we talk about anxiety, both of these, I think you're not going to be surprised, because you think at some point in your life, yeah, I've felt depressed. Now, it could be circumstantial. Maybe you don't have an official, major depression diagnosis. And I'm not going to get specific into the diagnoses. And another thing I want to say real quick is this video is not intended to take away from some sort of text resource that you are diving into. This perhaps could be used if you're commuting or as a review of the overview of depression. So when we think of depression, we think of, hopefully in the nursing process, the first thing I hope you're thinking of is assessment, okay? And I like to reference the A words, okay? What are your A words? And if you think of the prefix A, meaning lack of, so your A words for depression are going to be inertia, lack of energy, avolition, lack of motivation, anhedonia, and that's kind of like a lack of taking pleasure in things that normally make you feel happy, things that you enjoy doing, like reading or writing or, whatever it is. Okay, anhedonia. Okay, so we got inertia, avolition, okay, what about apathy? Apathy, lack of concern. Asocial, not antisocial. And we're going to make that distinction, but we'll just do a snippet right here. We're going to make that distinction a little more formally when I make a video on psychotic disorders / schizophrenia, okay? And we'll focus on schizophrenia in that particular video. But asocial, where people tend to, not be social. And that is different from antisocial. So you look up the difference between those two words. They are different, mean different things. Agitation. That's one of my A words I put in my comic book. I believe that's an important A word to put in there because some people may not necessarily present as tearful or, as far as subjective presentation, what someone may state is they feel helpless or hopeless, like they can't go on. And in this video, you'll see I look right here and you'll see where I've put I sketched out kind of like this overview, and I'll put the emoticons that represent, hey, someone may feel sad. And that's typical of what people tend to think of when they think of depression. However, someone may present flat. When you think of mood versus affect, they may have a flat or blunted affect. Flat, like no expression, or blunted, maybe minimal, okay? But back to that agitation, some people may come across like agitated, and it's underlying depression. So that is a word that I threw in there. So we got alogia. Did we say alogia? I don't think we did. Alogia is poverty of thought or speech. So meaning like, you ask them, you're trying to interact with someone that has underlying depression, and they just don't have a lot to say. And as far as inertia, I think we already talked about that. When you think of inertia and you think of this person, one of the things you should think of, and I'm kind of getting half a step ahead of myself, though, as far as your interventions, is they may not have the energy, y'all, to get out of bed, to do ADLs, to wash their clothes, or to clean their bodies, brush their teeth, comb these beautiful locks. I don't have beautiful locks. I used to, okay? But, okay. Now, another A word, that's not an A word, but I was going with this trend of A words, is a change in eating or sleeping habits and in attention. So the inability to focus in attention, okay, we're going to go with that A in attention, and a change in eating or sleeping habits. Now, for eating and sleeping, this could mean hypersomnia, or insomnia. Insomnia where like you just can't sleep, okay? Maybe you're not getting restful sleep. Or hypersomnia where you're sleeping a lot. Again, you may not have the energy to get out of the bed. And then as far as eating, that can also go either way. Maybe you're eating the house down, okay? Or maybe you're skipping your meals and you have a nutritional deficit. Okay, so did I say anxiety? If I didn't, I'm saying it now. A, anxiety. I put A, anxiety, in here with the A words because depression can present with other comorbidities. This means like they can have co-occurring mental health diagnoses. Now, some of those common ones that depression occurs with, one is anxiety, okay? It could be substance abuse. It could be eating disorders. It could be, there was another one that I wrote down and I forget what it was right now. Let me see if I can see my notes real quick. Sorry, you guys. Depression, eating disorder. Depression can co-occur. Well, look in your, again, you'll probably read that in your literature source, and I don't want to get too far off track here. Now, those are A words, okay? So that kind of gives you a nice overview of the signs and symptoms / characteristics of how this person may be presenting. As far as risk factors for depression, typically what you're going to read about is things like people that are over 65. And that makes sense. If you stop and think about, as we age, as we kind of get 65 and older, where people are starting to retire, people, 65 and older, if their social support is a major factor in resilience, okay, and that's just an aside, but as people age, their social support networks tend to lessen, and could lessen, and this could be because their friends are dying. Maybe they're widowed, their spouse passed away, they've retired. If they had a long-term career, it doesn't matter if they had long-term or short-term, still, people may tend to lose their sense of purpose because they don't, maybe if they identified strongly with, say, their career, then they've retired, and people around them that they love and care for are they either have passed away, or maybe there's reasons that themselves, the person, can't get out and about because decrease in function, physiological function. It is not fun to get older. I've already said, like, where your knees creak, and, people that deal with underlying chronic physiological diseases that have a hard time getting out of the house, going to connect with people. So you can kind of see just in that short little splash there why people that are greater than 65 have increased risk for depression. Now, one of the things you're going to read about in your text, and it is something to keep in mind, is when you think of differential diagnosis specific to the geriatric population, you do want to consider, as far as assessment goes, in text I've read before, you'll see where they compare depression to delirium and dementia, because those can have similar presentations. So it is important to kind of tease out, and it's always important to do that, to kind of think about, well, what could potentially be another differential diagnosis? What else could be causing this person's signs and symptoms, how they're presenting, okay? What else did I want to say about that? Okay, another risk factor that you'll read about in a lot of texts will be females over males. Now, as far as, just for a hot second, when we think about suicidal ideation or having suicidal thoughts, women tend to have more depression than men. However, when it comes to suicide, what you'll read about is that men tend to use more lethal means. So they tend to complete the suicidal thoughts more often. If they're having these suicidal thoughts and then they move to action to try to take their life, they tend to be, quote unquote, more successful because they tend to use more lethal means. Okay. As far as another risk factor, low socioeconomic status. Sorry, that was a tongue twister. How many wood chop chop wood, or whatever, okay? Low SES. You might see it abbreviated like that. Now, this puts me in the mind of, and I hope it puts you in the mind of too, something that's really been being talked about of recent, and maybe extending back a couple years or so, something like that. It's not a new thing. It's just where we've kind of coupled all these things together. And that's social determinants of health. And if you're not familiar with social determinants of health, I'll try to embed a link either below the video in the comments or something like that. The CDC has a great explanation for social determinants of health, and a great visual. I'm a very visual person. That's hence why I'm working on this comic book, and I've got another visual that I've embedded into this video. So, okay. What else? Substance abuse is another risk factor, and you, I'm sure, can make the leap to that. Now, as far as standardized scales that you can use to help assess for someone's depression, might be things like Beck Depression Inventory, the Geriatric Depression Scale, Hamilton Depression Scale is one that I wrote down. There's many others, but as far as test questions, y'all, maybe I need a drink of water real quick because I keep getting tongue twisted. But as far as test questions go, you might see that. Excuse me, I needed to wet my whistle, okay? All right, so those are some standardized scales. What are we going to do about this depression? Okay, as a nurse, we want to think, well, we always want to think holistically, okay? And I'm not meaning like, as far as a holistic approach, where you think, and again, once you read about social determinants of health, there are so many things that influence whether or not someone may be, if you think about mental health versus mental illness on a continuum, okay? And so where one person, or some people will say, may be able to spend most of their lives on the mental health side, okay, versus the mental illness side, or, and we're all, throughout our lives, there's no sometimes rhyme or reason. We don't know what our next card in life may be dealt. or what cards life may deal us. But as far as another component that goes along with what makes one person have, a propensity to or susceptibility to depression versus another that I didn't mention was, what about genetics? What about family history? So when you're putting all those things together, you do, as far as the interventions, you have to think holistically. Now, again, I've already said I'm going to make a separate video about antidepressants, but we know, in general, think about pharmacological versus non-pharmacological interventions. Now, right out of the gate, I'm going to put a hard stop. This is a stop sign to say, always think safety. Nurses always think safety. Okay? So yes, as we talk about interventions, I want you in your mind, and when you're thinking about test questions, and you're thinking about critical thinking, say you're walking onto the scene, and you're going to have that situational awareness. Okay, that's another buzzword these days. But it's true. We're all engaged a lot of times. I don't have I'm recording on my phone. So I forgot about that. I was going to say, a lot of us have our phones in front of our faces, and we don't have situational awareness. But as a nurse, say, walks into a room, they're always assessing the scene for safety. Okay? So that's your first stop. Hard stop. Are there safety risks for this person that is presenting with depression? Now, if we already kind of mentioned this, but what is one thing that comes to your mind as far as safety risk and that person that has underlying depression? If you said, I wish I had a bell right here. Ding, 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 ding. If you said, assess suicide risk, assess suicidality and homicidal thoughts. So suicidal ideation and homicidal ideation. Is that person having thoughts of harming themselves or harming another person? That's your first hard stop. Think safety. If they're saying yes, then you're automatically thinking for interventions to implement suicide precautions. What is suicide precautions? Well, I'm glad you asked. Suicide precautions is things like one-to-one. You place that person on a one-to-one. And typically, CNAs or techs will be the ones to carry out the one-to-one observation, meaning like one person is assigned to watch this person at all times that has an increased risk for suicide, increased risk for suicide. Okay? So they're monitoring this person at all times to make sure they stay safe. Okay? Now, in some of your text resources, you'll read something about asking the person to agree to like a non-suicide or a safety contract. And basically, this is nothing formal. All this is meaning is you're asking this person, hey, would you please agree that if you have increased suicide thoughts that you'll come and talk to me? You'll come and let me know. Of course, with the idea that they wouldn't take action, okay? Now, that's not a guarantee, okay? So that I wanted to stamp that out because, yeah, you'll read about that. But it's not, if someone is, having a hard time and they have, say, major depression, or maybe they're going through a crisis in their life, don't consider that a guarantee. But you may see that from one text to another, okay? Another thing, as far as safety goes and thinking about suicide precautions, is typically you'll see finger foods ordered. Typically you'll just see like, well, of course, when you're in an inpatient setting, and that's one thing I should have said, is someone who is having active suicidal thoughts, they're typically going to be admitted inpatient because they're at risk for taking their lives, okay? And again, I'll make a separate video about legal/ethical issues in mental health nursing. So if a patient's admitted inpatient and we place them on one-to-one, usually they just have it on a gown. And that's what I was getting to, is they wouldn't have like their clothes, they wouldn't have shoestrings, they won't have belts. They're admitted one-to-one if they're having active suicidal thoughts. And typically they get finger foods. They're not allowed, and this is typical for most inpatient units anyways. They're not allowed anything metal, anything that could potentially, they could use potentially to harm themselves. And that's why it's specific to finger foods. Because even if you give them plastic, a lot of times, they may break that plastic off to harm themselves in some way and such. So, anything else that I want to say about suicide precautions and one-to-one? I don't think so. Okay, now, other things, after we've kind of already talked about safety as far as our interventions, what about our milieu? What about a therapeutic milieu? What about therapeutic communication? If we think about non-pharmacological interventions. So our milieu should be safe, of course, and that kind of goes along with safety. In our environment, this is not the person, again, when you think of suicide precautions, that you want to give a private room. That typically they have a room, a patient room, inpatient status that is close to the nurse's station, if possible, okay? And you have that person assigned one-to-one where tech is watching them at all times. So empathy and communications always take empathy. Always take any expression of suicidal thoughts or homicidal thoughts. Homicidal meaning where they want to harm another person. And so suicide, of course, is self-harm. Or, wanting to take your own life, okay? But you don't ever take any of that lightly. It is a myth that if we ask people about, are you having suicidal thoughts or homicidal thoughts, that's going to increase their risk to take their lives. No. Actually, if we don't ask, who is asking? If you think about the mental health stigma, which still exists, okay? People still feel sometimes maybe shameful, or maybe they think that, they need to handle this on their own. They can do it. And that could be related to culture. It could be related to how that person was brought up. Could be related to their own kind of value system that, versus, say, like, if they're more intrinsic versus extrinsic, motivated, that they need to handle things on their own. Okay, you kind of get what I'm saying, all right? But if we're not asking as nurses, that's what I'm saying is, who's asking? So that is a myth, and you'll read that too. And more textbooks than not that I have read related to mental health nursing and just mental health in general, psychology, is assessing suicide risk. That is a myth, folks. Okay, so we got to ask. All right, I already touched on this a little bit, but when we talked about inertia a little while ago with our A words, what about ADLs? So we may need to help this person or prompt this person. Remember, nursing is about empowerment and promoting or fostering independence. But if someone does truly need help with their ADLs, we're going to help them, okay? Or maybe they need prompting. Hey, it's time to get up and take a shower. It's time to get up and get ready. Because that inertia, that underlying depression, may have them zapped, y'all, to where they just feel like, I don't feel like doing anything. I don't want to talk to anybody. Remember that asocial? I don't have the energy to get up. I don't have an energy to do anything, okay? So now, as far as other adjunctive or another kind of subtype of interventions may be complementary and alternative medicine. So some things as far as herbal medications, maybe St. John's wort or ginkgo biloba. One of the hot things I've seen lately is this, I can't call the name of it. Is it Boli or something like that? But there is some medications out there that can improve mood, can boost mood a little bit, but we also have to think of other things. So that's why I said pharmacological versus non-pharmacological. So make that distinction in your brain, and that will help you remember different types of interventions that may help. So other complementary or alternative medicine type interventions could be like light therapy. Say, one of the diagnoses you may read about is seasonal affective disorder. Now, I'm a Florida native. I'm a Florida boy. And I can tell you that summer is my absolute favorite season. But even I find myself sometimes, I don't have a diagnosis necessarily of seasonal affective disorder, but I'm saying this to illustrate that, hey, you can see that. You know, people that say live in states where there's not a lot of sunshine, like we have Florida sunshine here, or, you know, and California has a lot of sunshine. California gets very hot. Well, so does Florida. But, you know, think about Alaska, you know, where the amount of daylight versus night, or anyways, just where the seasons may have an effect on, say, this person's underlying psychological health or underlying mental health. So when you think of seasonal affective disorders, say if it's gloomy a lot of days, and that's what I was saying, sometimes if it's particularly rainy or gloomy, I may feel a little bluesy, okay? That doesn't mean I have a formal diagnosis of depression, and that's, again, I'm not getting off on diagnoses, okay? This is an overview about what does depression look like and what are we going to do about it. We're going to focus on the A and the I of the nursing process, assessment and intervention of ADPI. Okay, so what else? We said light therapy. Now, there are some alternative treatments that are not typically first-line treatments, and this will fall under your non-pharmacological. And these are things like ECT. So people that deal with, say, like chronic depression, you know, they may go through, or maybe they've been resistant, maybe they've tried multiple medications, so they may have some relief with electroconvulsive therapy, ECT. I'll make a separate video, okay? There's also things like transcranial magnetic stimulation, TMS. There's also vagus nerve stimulation, but usually these are not typically first-line treatments, okay? As far as pharmacological, your SSRIs, SNRIs are typically your go-to medications. What else do we want to say about CAM or adjunctive? Oh, what about simple things? Nutrition. Have you ever noticed when we don't eat the healthiest, it does affect how we feel. And also relates to inflammation and such like that, okay? Now, exercise, nutrition, yoga can kind of fall under that alternative complementary medicine. What else? Massage, meditation, mindfulness, breath work, art, music. We have to, as nurses, get better at thinking of other things that could help our patients, okay? Medications. I'm not against medications. I'm just saying holistic. Think holistic care. What else, people? All right. Now, this is where I'm scanning my notes to see, is there anything else I wanted to say? All right. I don't see anything there. I don't see anything here. Please feel free, y'all, to subscribe to this channel. If you like this video, or make a comment, what kind of videos would you like to see? What kind of content would you like for me to cover? I'm just looking over my notes real quick. Oh, I think that is a nice overview. Okay. Again, you are going to need to know psych meds. So I'll make a separate video related to that. I'm almost at 30 minutes, and this is perfect. This is a nice overview. You can listen to it on your way to work, on your way to school, and use this as a separate tool. Meaning, like, do not make these videos the only source for your studying. You should have some sort of text you can get into. Maybe listen to podcasts. Maybe find a movie that illustrates depression. And I'll see you guys later. Thank you for tuning in.